had a scan, like it was we were not able to maybe many people were not able to interpret this scan and क्या वो इंटरनेट नहीं चल सकता आपका and it was available on that interactive content, but since there are problems with the internet and I'm not able to show that on screen. Okay. Okay. This is the OCT scan, and so it made a lot of people's many OCT experts confused. So it is even theoretically impossible to have some hyperreflective structures posterior to your choriosacral juncture which are visible on your OCT scan. You can see these are the white structures with posterior shadowing in the vitreous, but again these structures are visible posterior to your choriosacral juncture as well. So I had this B scan maybe a year back or so. There were a lot of people, even OCT expert graders, were confused. What can it be? So I suppose most of you people have guessed it now. What can it be? Anyone? No. Cardiac threads are not located in the vitreous. Okay. These are certainly vitreous opacities with posterior. I'm not talking about that diagnosis. I'm not even concerned about the diagnosis. But why do you see these brighter structures posterior to your choriosacral juncture? This is the main question. If it was cropped, it is a mirror artifact. So there are a lot of the vitreous opacities, which could be the steroid hyalosis or whatever. We are not talking about those pathological correlates. We are just talking about the artifacts, and these are the mirror artifacts which were visible posterior to your choriosacral juncture. Otherwise, some smart doctor might be able to write a paper and with some newer pathology and a newer entity. So it is a mirror artifact. You have to identify the type of artifacts.
In mysticoid movement of the eyes, how can we control such kind of artifacts?
You can try again and again and your best.
This is the way to control it.
Certainly, we do not have any option to stop those nystagmoid movements, and we cannot do great with just. We have to be cautious while interpreting those scans. If we are having those motion artifacts, we will be looking at the scan very cautiously, and we will be putting a note at the bottom line that due to the motion artifacts, the reliability or whatever is reduced. Yes. So we will be talking about vitreoretinal interface disorders. We will be having some example cases. We cannot discuss each and every disease on OCT in this short course, but we will be talking about the most important diseases. and how the OCT appears in them. And the most important thing is describe an OCT scan. So first, let's begin from the vitreoretinal interface disorders. And the first thing is the physiological PVD and posterior vitreous detachment. Initially, the physiological posterior vitreous detachment is next. हो गया ठीक है. So it's because of the synchronization between the vitreous liquefaction and vitreous separation. And with aging, the vitreous becomes liquefied, and if the both in the synovitis and the synchisis are not occurring in a synchronized manner, if they both are not synchronized, it becomes the pathological PVD or vitreomacular adhesions and vitreomacular traction. In physiological PVD, both things have to occur in a balanced pattern and in synchronization with each other. So in normal physiological, in aging eye, normal physiological posterior vitreous detachment, first you get an extramacular posterior vitreous detachment, then we get a parafoveal. It keeps on detaching towards the center of the fovea, and then from the parafoveal it goes to become the perifoveal. And on this projector you cannot see, but if it was well visible on my screen. Can somebody turn off the light? Again, it's not visible. Over here it's visible, but from yeah, I can see this over here, and this is there is the scan, the detachment of vitreous over here. So this is a parafoveal detachment, and this was the extrafoveal, extramacular detachment, then paramacular, and you can see this is detached from all this area, but it is attached at the foveal pit, at the fovea. So this is again not pathological, and this is the complete posterior vitreous detachment. So if the posterior vitreous detachment is not completed, it prolongs, it remains over there, it becomes the vitreomacular adhesion syndrome. So symptomatic vitreomacular adhesion. So some other authorities consider that even the incomplete physiological posterior vitreous detachment to fall in the spectrum of vitreomacular adhesions, but few people consider vitreomacular adhesion to be purely pathological. So whatever the classification system you adopt, most important is to know if this is normal or if this is abnormal. So there is the vitreomacular adhesion and vitreomacular traction, and you can see that the retinal there is the adhesion between your vitreous line, your vitreous with posterior vitreous and your internal inner retinal boundary. So there is the attachment, but if you look at this scan, so this is a case when you have to be very careful interpreting your OCT scans. If the retinal structures and retinal morphology and retinal elements are good, you can observe and it can resolve. But if you fail to identify the structural abnormalities associated with this vitreomacular adhesion, then you may delay the diagnosis and the outcomes may be different. So, this is the case where there is the traction. So there was no traction, and there is traction certainly. Do you see a small black discontinuation in that your what here? Anyone? Not all exist. We are just talking about is there any discontinuation and that particular layer. So what layer is that? this is right. So there is the disruption of your ellipsoid zone band, which corresponds to your photoreceptor, the health of your photoreceptors. So and this traction has got, so in physiological PVD you can see there was no change, no disruption in the retinal elements, and in this vitreomacular adhesion or vitreomacular traction, and you can see there is the disruption of your ellipsoid zone band. I've been very habitual to call it the photoreceptor integrity layer because this term was coined by an optometrist, so certainly I have to acknowledge him all the times, and he was the pioneer. There's one reason I frequently call it PIL, but certainly this term is now not being used very commonly. So whether it's PI, photoreceptor integrity layer, or the ellipsoid zone band, or the inner segment, outer segment, this is the layer which this is band 2, which tells you that the photoreceptors are healthy or not. So you can see the photoreceptors from this area are detached, and this layer is superiorly shifted, slightly elevated, and there is the disruption of this structure. So this is the traction has just caused the disruption of your photoreceptors. And this is another case when you can see there a thin brighter line inner to your internal limiting membrane, which is epiretinal membrane, and there is the traction from posterior vitreous, and certainly there are changes at the level of outer segment. You can see the photoreceptor dehiscence, and this is another case with vitreomacular traction syndrome, and the vitreomacular traction syndrome can just cause your macular hole and the retinal thickening, retinal distortion, and a lot of things. So this was the classification given by International Vitreomacular Classification Group in 2013. So they classified it to be vitreomacular adhesions, which can be focal if it is less than 1500 microns, and it can be broad if this is more than 1500 microns, and it can be isolated as a standalone condition, or it can occur with other diseases. But according to the classification from IVTS group, there should not be any abnormalities in the retina, in the retinal morphology or retinal structure secondary to that adhesion. And this is from the IVTS group. So some groups believe that there should be abnormalities in VMA and VMT if this is less than 1500 microns, this is focal vitreomacular traction, and if this is broader than 1500 microns, and it is a broader vitreomacular traction, can be isolated again, or can be concurrent with the other diseases, so there will be structural abnormalities in the macula and the retina. And in full thickness, there are the full thickness macular holes that can be small, and if they are less than 250 micron meters in terms of the basal dimensions, and not in full thickness hole, you will be having full tissue defect in the center, in the macula. In the macula, you will be having loss of all the macular structures. But if we are talking about the basal dimensions, and if this is less than 250 microns, and this is small, and if this is medium, it can be up to 400 microns, and more than 400 microns will be the large macular hole. It can be with or without vitreomacular traction, and it can be idiopathic macular hole, or can be related to the other conditions. So now you can see this is a case with vitreomacular traction, and the vitreous is detached from all the area except for the central fovea, and it's pulling the retina anteriorly. So there are the disruption of the posterior structures, and you can see the loss of your photoreceptor integrity layer, and even distortion of your retinal pigment epithelium. And this is another scan with vitreomacular traction, and you can see the posterior vitreous face pulling the retina inwards, and there are cystic spaces in the inner retina, and you can again see the schisis cavities over here at the level of the outer plexiform layers. So there, this is extreme case of your vitreomacular traction syndrome. If this was managed in time, you could have, but you again have to look at the ellipsoid zone band and other bands in the outer retina. This patient could have a good vision even. Despite that, if this patient gets well managed, the vision restoration will be remarkable, because the outer ellipsoid zone band and this scan is not lost too much. So once this is operated and is well managed, the patient's visual outcome can be great. This is another case. So there is no vitreomacular traction at all. Vitreous is completely detached from this area, but you can see retinal thickening, and what else? It's normal. The most important is you can see the cystic spaces and schisis cavity. You can see a cyst over here, another cyst over here, and the schisis cavities at the level of outer plexiform. And so you can see the complete posterior vitreous detachment with an operculum over here, and this with a partial thickness macular hole. So this is not full thickness macular hole, and you can see there is some continuation at this level, and you can see the cystic changes over here and schisis cavities at this level. So this is a partial thickness macular hole with complete posterior vitreous detachment. So the vitreous had traction on that macula. It caused the retinal thickening, the schisis cavities, and cystic changes in the retina, and which later on just had detached from the macula and leaving the macula behind that. So it can just reverse back to its normal position depending on the course of this disease, but this is not the topic of this talk. And this is another case. Can anyone explain it for me, please? There is a thick epiretinal membrane with a thick posterior vitreous space having traction on it, and there is loss of foveal pit, loss of gross retinal morphology, and it's markedly increased retinal thickness. You can see the cystic changes, you can see the loss of ellipsoid zone band, and you can see the loss of your even other layers. You cannot identify if the outer nuclear layer is well preserved. You cannot. You can just try to identify this outer plexiform and even inner nuclear, but it is grossly deformed retinal structure. So this is an extreme of vitreomacular traction syndrome. This is a macular pucker. You can see the pucker membranes over here causing the exaggerated retinal deformed retinal morphology or deformed retinal structure. So when reporting this, you can say that there is a thicker epiretinal membrane with profound thickening of the retina and gross deformity of the retinal morphology with loss of the outer retinal elements. So this is another case. Is that a macular hole? No? Yes? So this is a macular hole, but this is not a real macular hole. This is a lamellar macular hole. You can see the lamellar macular hole is different from the partial thickness macular hole. So this thing should be in mind, and this can occur with or without an epiretinal membrane. You can see the clefts, and there is the foveal thinning, and you can see the clefts in the inner retinal floor, and you can see a cleavage between inner and outer retina. So this mostly these lamellar macular holes are because of two reasons. There is a brushed retinal cyst. It can be because of that extreme macular edema, which is just damage the retinal morphology, inner retinal morphology, and when the cyst is broken, you will be having appearance like this. This can be secondary to the cessation or even the progression of a macular to full thickness macular hole formation is halted at somewhere in an intermediate stage. So you have to identify it. Most of the lamellar macular holes would be having, all of the macular holes actually would be having a cleavage between an inner and outer retina and appearance would be like the letter W of English alphabets. It will be looking like a W. You can see this is a macular, and this is a lamellar macular hole, and most importantly, outer retinal structures are fine. You can see, and you can identify your outer nuclear layers, even the part of the plagiform layers, and your outer ellipsoid zone. Then it is also disrupted, but it's intact in most of the skin. So, is that a macular hole or a lamellar macular hole? Alright. So, in full thickness holes, if I scan from full thickness hole, I will not have the full thickness hole. So, in full thickness hole, you will not be having any of the structures of the retina in front of the hole except your retinal pigment epithelium. And over here you can see the outer nuclear layer is fine, and your other outer retinal bands are fine. So this is not a hole. You can see the epiretinal membrane over here. I just press the arrow to highlight those those epiretinal membrane. So this is because you can see